Hello and welcome to our virtual rhinoplasty meetings. My name is Dr Cameron McIntosh and I'm the president of SORSSA, or the Society of Rhinoplasty Surgeons of South Africa. So during the coronavirus lockdown period, we decided to have bi-weekly Zoom meetings. We specifically chose teachers from around the world to be able to cover many topics. Unfortunately, due to patient confidentiality, we can't actually show you the real talks. However, the very interesting interactive question and answer sessions is what we're going to be showing you. We want to give a shout out to our colleagues around the world fighting coronavirus. Please look after yourselves and be safe. So I'm not going to say anything more. Enjoy the show. Episode 10, we've moved back over to the United States to listen to Dr Toriumi giving us his talks on how to avoid and manage complications in rhinoplasty. A phenomenal talk.
Thank you for your attention. I know I was covered a lot of material. We can take some questions now.
Sure. Prof. Dean, thank you so much. I'm so glad you said something about your book at the end. I was going to pertinently ask you if you can let us know how we could get hold of that. I've got so many questions coming in, as well as on the YouTube video channel. Let me jump ahead and see what I can get here. Okay. So, sorry, just before I start, please understand that Harry sent out the link for the CMEs. So if you want CME forms, please fill those in. So let's get cracking here. We've got, starting with Rui Xavier from Portugal. Thanks for the wonderful lecture. When you harvest the seventh rib, do you leave the inferior edge of the rib to keep the contour of the thoracic cage?
Yeah, so when you take 7, 8 is always there. So if you leave 8 intact, you still preserve the stability of the chest wall, you preserve the contour of the chest wall, but you're above the diaphragm. You know, I talk to people, they tell me, you know, Dean, I want to do rib, but I'm afraid of a pneumor. I tell them, just go to 7, just go 1 rib lower, and you're below the diaphragm. I take anterior and posterior perichondrium on the 7th rib frequently. And I frequently will go in, I'll just peel the perichondrium off the muscle. The muscle is very thick underneath the 7th rib. And you're below, you're not in the chest, so you're not going to get a pneumo unless there's some really weird anatomy.
Okay. Aniketh wants to know, could you share your osteotomy technique and sequence, please? Okay,
so typically what I'll do, if it's a primary, I'll do the manipulation in the bony ball unless I'm doing a preservation, dorsal preservation type situation. I'll do a hump reduction, then I'll do a medial if necessary, and then I'll do right, left, lateral osteotomies. That's my typical way of doing osteotomies, but again, now we're starting to do some dorsal preservation type stuff. So again, it varies there. There we're doing the left lateral, then we're doing the transverse, and then I wait on the right lateral until I do the septal work. And that's how Milos does it.
Okay, a question from Marco would like to know, for those vestibular stenosis reconstructions, what if we have no symbicontia anymore?
Okay, so if you have no symbicontia, what I have done in those situations is you can implant, you have to do it in stages. Well, you can take a piece of, you can use septal or rib cartilage, you can use ear cartilage from the other ear, you can implant a piece of cartilage underneath the thinner vestibular skin, and then you can come back at a secondary stage and pull out skin with the underlying cartilage. The other thing that you can do is you can take a graft from the ear, even though there's no cartilage there. What you can do is take the skin, try to get some of the underlying tissue, which could be perichondrium, and maybe have some perichondrial tendencies, and then you can use that. But in those situations, you have to use the smaller skin island technique, otherwise you may not have viability of your graft.
Thank you. Ted Ra would like to know, do you use lateral extension grafts in primaries? And what osteotomies do you use to widen a narrow midvault?
Okay, so primaries, I'm going to do lateral osteotomies in most patients. I'm going to do medials in some that have a wider dorsum. For the midvault, if it's not a DP case, then I'm going to use spreader grafts. And I use spreader grafts over spreader flaps just because I feel more confident with the spreader grafts. There are some patients I'll use spreader graft with spreader flap, but it's very rare I use spreader flap alone. I just don't feel I get enough stability in the mid-vault, particularly with short nasal bones, to stabilize the mid-vault area.
Awesome. Barris says you are a magician. Ray Friedman would like to know, after antibiotic treatment and removal of septic alloplast, when do you do reconstruction?
Okay, read that again, please.
After your antibiotic treatment and removal of septic alloplast material, when do you do reconstruction?
Okay. Well, this is a little controversial, but what I'll do, even in lieu of an infected implant, is the key point is if there's granulation tissue. If there's no granulation tissue, I'll take the implant out, I'll do immediate reconstruction, and I'll put those irrigation catheters in for 5 days. And we do a lot of that just because I get a lot of Asian patients who come in with infected implants. So it's rare that I do a delayed reconstruction. If I open a nose with an implant and there's granulation tissue, then I just take the implant out, put a little bit of, try to get some kind of support by using the intact, whatever tissues are there, close, and then come back in about 2 months. I usually wait 2 months just because that's about the right amount of time before the nose really starts to collapse, and then I'll go ahead and do a reconstruction.
Awesome.
But I'm telling you, if you do the irrigation catheters like I'm talking about, you will be amazed at how you can get your infection rate under control.
Yeah. Thank you. Erin wants to know, in what patient would you go straight to rib harvest for a primary rhinoplasty?
Okay, so I do a lot of Asian augmentation rhinoplasty. Their septum is about that big. So I can't really, and it's very weak and thin. So I'll go to the rib immediately for those patients. I do a lot of primary cases that are pretty bad, like Wegener's, saddles, severe traumatic, post-traumatic crooked noses. And in those, I will use ribs. So I would say of the primaries, if you include the Asian augmentation cases, we're probably using rib in probably close to 30% of cases. But people say, well, that's crazy. Why would you use 30% of your primaries with rib? Well, that's because a lot of them are major Asian augmentation cases. If you take those out, that number drops significantly, probably to less than 5%. But as a caveat, my practice is skewed, and some of the people who have not had prior surgery, they look terrible. They have horrible problems, Wegener's noses, cocaine noses, and those are primaries. They never had surgery before, but they still need a rib. So that kind of skews that number.
What about your African-American patients?
I think those cases are augmentation cases. I treat them very similar to the way I treat an Asian patient. I stretch the skin. So I usually do a radix graft of some sort. I put in a strong caudal extension graft and I push the tip out and I drag the base up. I showed you that one non-Caucasian patient. I pulled the base up on a strong caudal extension graft. You can get really elegant, natural looking results if you use these structural techniques in ethnic patients. I think it's a really good combo.
Awesome. So there are a whole lot of questions on the YouTube going through as well. I'm just going to carry on the Zoom one here. It says, so a question from Guillermo wants to know, when do you decide to use lateral crural strut grafts with and without perichondrium on the undersurface?
Okay, so that's a good question. So any patient who's say under 30 or over 50, I absolutely want to use the perichondrium if at all possible. And I put it on the undersurface. Couple reasons. In the younger patient, I think it helps minimize late warping. In the older patient, it helps to cover the graft to prevent it from to allow it to more rapidly revascularize. What I found in my patient population is patients that are over 60, 55, 60, when you look at the rib, it's calcified, it's brown. And when you go back and revise these people, the tissues aren't even attached to the graft. There's almost like a space between there because it never really integrates. And so that's why I think they're at higher risk for resorption and higher risk for infection. To get around that, if we leave the native perichondrium on the cartilage, that will give you better survival. I have actually gone to the extent where I've done multiple stage surgeries in patients. I'll suture perichondrium to the old rib cartilage, bank it for the next stage, and then come out, take the graft out that has now the native perichondrium attached to it, and then use that as a graft. I feel it's that important to have that native perichondrium attached. Native perichondrium is different from suturing perichondrium. The native perichondrium is integrated and vascularly efficient with respect to that piece of cartilage. So I think if you use the native perichondrium, don't cut it off. Use it to your advantage. Also know that it's going to bend in that direction. Use the bend to your advantage.
Awesome. Alessandro from Brazil wants to know, is it possible to use composite ear in columellar retraction?
Yeah, you know, I had a case, the last case I was going to show had just that. I took it out because of time. So I unfortunately see a lot of patients who have loss of columellar skin. So what I do in those situations, I'm going to let it heal. I'm going to let a little granulation tissue form. I have a lot of people, friends of mine, who call me and say, Dean, I had some columellar loss. What do I do? And I just tell them, I said, let it granulate, let it heal a little bit, then get a composite graft from the ear and use that to repair. The problem with the composite graft on the anterior surface is the skin is very thin, tightly adherent, and there's no subcutaneous fatty layer. So there's a discrepancy between the thickness of the skin and the thickness of the skin at your recipient site, i.e. the columellar skin. So what you can do is take a composite graft from the back of the ear. Take it from the back of the ear, and it has subcutaneous tissue. It's not quite as vascularly sturdy as the anterior skin, but it works well. So then what you can do is put that in and use that to replace the columellar deficiency. If you use the anterior skin, what you need to do is dissect a little bit of that skin for about 1 millimeter around the graft, or maybe 0.5 millimeter, so you can get a good closure. And then I tell patients later, you may have to come back at a later point in time and get a microfat injection into that to plump it out.
Awesome. Lysandra
composite grafts are great for columellar reconstruction.
Well, he's persisting with another question here. He wants to know what the real difference is between nano and microfat and the indication of each one.
Okay, so nano fat is 400 to 600 microns. Microfat is about 1 to 1.2 millimeters. So it's a particle size difference. The other difference is nano fat, you're not doing it for augmentation. You're doing it primarily for the stem cells. Okay, so if I want augmentation, meaning making the skin thicker, I'm going to use microfat infused into the temporalis fascia. If I just want stem cells, because I'm putting it in temporalis fascia underneath a tight columellar closure, and I'm concerned about the vascularity, I'm going to infuse nanofat. Nanofat, temporalis fascia, underneath the columellar closure, underneath the tip closure. That's going to give you enhanced vascular supply and vascular ingrowth in that area. Very distinct differences between the two.
Lucas is asking, please could you repeat the book discount code? I don't know if you want to put that up on the screen.
So for international, it's
you're welcome to share your screen again if you want to put that up.
Let's see. I think it's you know what? I'll put it up on the
group day.
On your group thing, yeah.
Okay, cool. Okay, I'm going to jump over here to a YouTube question. Eric Post wants to know, mind-blowing results, great lecture. Pushing the lateral crural strut grafts down or placing them in a soft tissue pocket, how do you ensure the placement is symmetrical?
Okay, so that's a really, really good point. So a couple things. Number one, unfortunately, when people do this technique of repositioning, they're putting the pockets in the wrong place. They're putting the pockets where you make your alar rim grafts. It's not the same pocket. You stay away from the pre-vestibular or pre-marginal incision so that you don't go caudal to the marginal incision. You basically follow your marginal incision laterally and you make your pocket straight laterally from there. The other key point is you don't angle the pocket up cranially. You angle the pocket down towards the upper lip. Otherwise, you get a bump on the side of the nose. The other thing
Mm.
is when you put your graft in and you make your pockets where they should be, hopefully symmetrically, then when you're looking from the frontal view, look at the tilt. So the tilt of the cartilage is very important. You want symmetric tilt so that the caudal margin of that cartilage is slightly tilted up, not too much. If you go too much, then you get a fullness there from that edge. Just a little tilt up. And if it's not symmetric, then you take your little soft cartilage scar tissue onlay graft and you lay it over the domes and you suture it to the caudal margin of each lateral crust, and that will even it out. And if you need to, you can put an additional suture along the cephalic margin. But at the end of the case, you want those caudal margins symmetrically positioned and the tilt symmetric. And if you make your pockets in the correct place, that's not a difficult task. You know, when people get, you know, all these asymmetries, it's because the other thing I should tell you to do is at the end of your case, take a photo of your tip cartilages right before you close. So if you have a problem, you can look at it and you can see what the error was. That's really an important thing.
Awesome. Prof, are you able to take your screen share away? Then we can see you again. Whilst you're busy with that, there's a question from Shah, and the question is, which tip suture techniques don't work well in Asian noses?
Which what?
Which tip suture techniques don't work well in Asian noses?
Okay, so in Asian augmentation rhinoplasty, it's a completely different operation. You don't use lateral strut grafts unless it's a revision with alar retraction. You don't reposition. The lateral crura are essentially just there. They're bystanders. So you use what I've been doing for many years is I put in a cephal extension graft and I essentially tension the lateral crura and just flatten them. And then I put a shield graft with articulated rim grafts in. So everything gets built on top of the existing lateral crura. So you don't use the same techniques you use in the Caucasian patient and the Asian patient. The Asian patient operation is a completely different operation, both from the standpoint of management of the dorsum, as well as from management of the nasal tip. The nasal tip is an extension graft with or without shield graft, lateral curl grafts, and articulated rim grafts. That's a completely different operation. We don't really do that in the Caucasian patient. And the main reason why you don't reposition in the Asian patient is you're going to create a base that's too wide, and Asian patients will frequently have a hanging lobule, and you don't want to make that worse. And you don't want to force yourself to have to do a base reduction. If you simply project and you do midline augmentation with lateral compartment support with an articulated rim graft, you probably won't have to do a base reduction.
Wow, that's cool. Philly over in Brussels wants to know, wonderful talk, thank you. What is your ideal radix graft?
My ideal radix graft in a Caucasian patient is a soft piece of, what I'll do is I'll release the lateral crura if I'm doing repositioning, and I'll take the sesamoid cartilage segment, that's the lateral most aspect of the lateral crust, and I use that as the radix graft because it's a soft piece of cartilage with attached soft tissue. And I suture it into I put it in the radix and fix it transcutaneously, and it works just great. If I need something bigger than that, then I'll maybe take 2 pieces of cartilage, suture them together, soft pieces, and put them there. I don't like hard radix grafts unless it's a big radix graft, like I might use in a non-Caucasian patient or in an Asian patient.
Okay, thanks. George in Greece wants to know, do you use dilators, especially in cases where you use composite grafts?
I don't use dilators, but I use the lateral wall splints. The lateral wall splints are these little pieces of plastic that go on the side wall of the nose, one internally and one externally. And basically what it does is align the composite graft with gentle compression. And I really believe the gentle compression is important. And that will help, I believe, in increasing the survival of your composite graft. It also protects it for 7 days from crust, trauma, movement, manipulation. I think that helps a lot.
Okay, thank you. Ibrahim would like to know, thank you for a great talk. Can you please kindly mention your protocol of antibiotic irrigation?
Okay. So there's 2 things. There's the antibiotic soaks, which I do on everybody. Everybody gets an antibiotic soak. It's a 2x2 gauze. They take a liter of saline, sterile saline, and they put 2 600 or 500 milligram capsules of ciprofloxacin in the water, and then you leave it there have them leave it there for about an hour and then shake it and it dissolves. Or you can crush it and put it in there and shake it. That is the base solution. Then you have the patient take the 2x2 gauze. They pour a little bit of the solution into the cap of that saline, just enough to go about a half a centimeter in the bottom. Then you put the 2x2 gauze in there, soak it. Then you have them put it in each nostril and push it up with a little cotton tip applicator, and it sits like a mustache dressing underneath the right across the columella. It goes in about an inch on each side. You leave it there for 30 minutes. And what this does is clear out all the junk. I mean, I think what happens is when you do these rhinoplasties, you get crust that sits right on top of the marginal incision. And of course, it's got bacteria in it, and it's just feeding right into that wound. We don't want that. What we want it to be is clean. So we put the soaks in, that does a debridement, and it basically, you get a transmucosal low level of antibiotic in those tissues. And that, I believe, really helps a lot decreasing the chance of infection because it's delivered right to the site where you want it. The irrigations are different. The irrigations basically go into the marginal incision or into the columellar area. It's a small catheter. It's only like a 22 gauge angiocath, gets sutured in place, and that sits there in the tip area, and you irrigate with a half a cc of the same solution, the Cipro solution. You do that every 3 hours, very slowly, so painstakingly slow that it could take 3 minutes to do a half cc. Otherwise, it's painful to the patient. And then it may dribble out of the other incisions, but what it's doing is it's putting antibiotic over your tip cartilages, preventing any bacterial overgrowth, and it really works wonders for preventing infection. So this is what I do on all secondaries and complex. Anyone who gets rib gets the irrigation catheter. And that's different from the suction catheter. Okay, the suction catheter goes in thicker skin, bigger skin envelope, and you put it on red rubber test tube suction. I'm shocked at how much solution comes out of there. I mean, you'll come back on post-op day 1, and it'll be half full with serous solution. So otherwise, that is going to be some of that staying in the nose. And of course, that's going to contribute to scarring and thickness. And I have found that when we do these catheters and put the suction on there, the skin envelopes look much better early on, much better.
Oh. So, Prof, we're going to have time for one last question. We could carry on for hours. There are so many questions that people want to ask you. Hossam Foda says, well done. Enrico Robotti is congratulating you. It's fantastic. So this is the last question. When do you use rim grafts?
Okay. So I use rim grafts in several different capacities. So if I'm doing a primary and I just put in a dome suture, no lateral construct grafts or no repositioning, and I need a little alar margin support, then I'll put the rim graft in. I'll use the rim graft similar to the one Rod Rourke uses. It's a thinner graft. It's only sutured very loosely to the skin, and it's not fixed to the tip in any way. That's different from the articulated rim grafts that Rick talks about. So when I articulate a rim graft, I suture it under the dome or to the lateral edge of the shield graft, and that's my workhorse in patients like Asian patients where I want support to the lateral compartment, but I don't want to create bulk, and I don't want to create widening of the nasal base, because when you reposition, frequently you make your base wider and then you have to do more base reductions. This won't do that. This is much less involved, and my rim grafts that I use for that purpose are somewhere between, size-wise, or somewhere between the ones that Rick uses and somewhere between the ones that Rod uses. So they're kind of in between those two. But it serves the purpose. The key, though, is lateral compartment support. You saw that patient I showed with the really severe ileal retraction. That is not a healing issue. It may be due to healing, but it was a deficiency in my technique in the treatment of that patient, which got worse and worse and worse over 20 years. There's no other way to explain that.
Sure. Well, Prof, you pushed us over 400 people who logged on tonight, which is quite amazing. But I just really want to thank you for your your humility and showing these mistakes. It's amazing to be able to see tonight, and you're walking us through more than 30 years of rhinoplasty and showing us where the mistakes are. And yeah, I know for myself, I've got so much more to learn. But so from our side, just a sincere thank you, and a huge shout out to everybody who's logged on tonight from all around the world. We really appreciate it, and we appreciate you guys coming to learn. And Prof, thank you so much for your time and effort that you've put into this.
Thank you, Cameron. Thank you for organizing all this. It's really special.
It's great. Well, good night, everybody, and we'll see you guys next week.